Welcome back to What Your GP Doesn't Tell You, the podcast for both doctors and patients with me, Liz Tucker. In this week's episode, I'm talking to NHS consultant neurologist Dr Suzanne O'Sullivan, who, in a new book, The Age of Diagnosis, Sickness, Health, and Why Medicine Has Gone Too Far, published by Hodder, argues that a range of conditions from autism to ADHD are now overdiagnosed, which is completely recalibrating the difference between sickness and health. She says creating large numbers of new diagnoses, which turn healthy people into patients, carries risks for both our mental and physical well-being, and that we should be cautious about unnecessary medical tests and investigations that may cause more harm than good. A new study suggests that CT scans may be responsible for causing 5% of cancers in the US. Suzanne reveals, perhaps surprisingly, that apart from a small benefit for large bowel cancer, cancer screening has not been shown to have an impact on all-cause mortality, suggesting that although we may be finding cancer earlier, that doesn't mean that overall we're saving lives. But before we get to Suzanne's interview, a brief request from me. If you enjoy this podcast and would like to leave a review on Spotify or Apple, that would be much appreciated. It really helps. You can also become a paid supporter of the podcast at patreon.com/whatyourgpdoesn'ttellyu or via PayPal on my website, whatyourgpdoesn'ttellyu.com. A huge amount of work goes into both the research and production of this podcast, so even a small amount of money makes a huge difference. And you can find out more information about the pod on my website, where you can sign up for the podcast mailing list, follow me on Twitter at Liz C. Tucker, and on my Substack account, liz.tucker.substack.com. Many thanks. And now back to Suzanne's interview. Dr. Suzanne O'Sullivan works as a consultant in clinical neurophysiology and neurology at the National Hospital for Neurology and Neurosurgery, and for a specialist unit based at the Epilepsy Society. She specialises in the investigation of complex epilepsy and, in addition, has a particular interest in psychogenic disorders. She's also written several books which have been shortlisted for awards and won prizes. Here's Suzanne's interview. So, Suzanne, welcome to the podcast.
Thank you for having me.
When did you first start to worry as a doctor that the blurring of boundaries between sickness and health were leading to more people being diagnosed with medical conditions?
I think it's something that's really crept up on me over the last kind of couple of decades. So just to put it, my career into context, I qualified in 1991. So I've been a doctor for nearly 35 years, not quite. The patients that I see now, and because I'm a neurologist working with epilepsy, a lot of my patients are really young, so let's say in their 20s. There's been a real kind of accruing of people who have long lists of medical diagnoses coming to me that simply didn't exist 20, 30 years ago when I qualified as a doctor. And of course, I know that people will argue, well, we're getting better at making diagnoses and we're searching for things and our tests are more sensitive. But what I'm seeing amongst the young people who come to see me is that they have 5, if they're lucky, only 5 diagnoses. Some have 10, some have 15, but they're not leading anywhere. A diagnosis is supposed to explain something that leads to some sort of support or treatment that results in either an improvement in your symptoms or improvement in your life. And what worries me about all of these diagnoses is what I'm seeing is people are gathering diagnoses that aren't leading anywhere. They're just leading to more diagnoses sometimes. And that's been my concern is, I see people getting more diagnoses but not getting better.
I suppose one tends to think that the benefits of diagnosis are obvious, and that's true, I suppose, if there's a clear treatment. But it's much less clear if there is no effective therapy.
So obviously the perfect situation is you get a medical diagnosis, there's a treatment for that, and that results in you getting better. But of course, a diagnosis doesn't need to result in a complete resolution of your symptoms to be helpful. I care for a lot of people with very difficult to treat epilepsy, for example, and 70% of people with epilepsy get better with the treatment, but there are 30% of people who don't. But the diagnosis is still very beneficial to those people because it explains what's happening. It makes them part of a cohort who they can get support from. It puts a name to what's going on and makes them subjects to research going forward. So if new innovations come about, they will be able to access it because they have a diagnosis. So a diagnosis can be helpful in lots of different ways, even if it doesn't result in a cure or even if it doesn't result in symptoms resolving completely. However, having said all of those kind of good things about diagnosis, I think what we don't talk about nearly enough is the harms that come with diagnosis. And I think people sort of are in pursuit of labels because they believe that a diagnosis is an unerringly good thing. And we're in pursuit of labels because we're not aware that a diagnosis is not inert. It has a power all of its own to potentially bring negative things to people's lives. I'm not writing about overdiagnosis to discourage people from looking for answers. I just want people to understand a diagnosis has negative impact that comes with it. So be absolutely sure before you pursue that label that positive things definitely outweigh the negative things.
Sort of makes sense, doesn't it? If I go to the doctor and I'm feeling a bit under the weather and he or she says, don't worry, you'll feel much better in a couple of weeks. But if they say, oh, you've got this nasty thing, there's not really anything you can do, you'll just have to cope with it, I will probably come out of the doctor's surgery feeling worse.
Yeah, I mean, it completely changes your relationship with your body when you're given a diagnosis, because first of all, it sort of draws your attention to the things you cannot do or to your symptoms or the things that are bothering you. But it also has the power to potentially create new symptoms, which might sound a bit counterintuitive to people. But let's say I was given a medical diagnosis and I went to my doctor with headache and I was given a medical diagnosis and I look up that medical diagnosis or I learned from my doctor that it doesn't just cause headaches, it also causes tiredness, it also causes weakness, it also causes bladder problems, whatever. Then the natural tendency is that one's attention, which was once just on one's headache, is now also looking out for other signs of this disease label that I've been given. You know, all of our bodies, as I always say, are a mess of white noise. At any point in time, if you pay attention to any particular function, it begins to feel unnatural or the body can feel unnatural. A medical label can focus you on your body until your body begins to feel unnatural and that produces symptoms. As I say, you know, that doesn't happen for everybody. It's just something important to consider if you are getting a diagnosis for a problem that is not necessarily very disabling to you, then you could find that these negative things outweigh the positive things.
But it's amazing how psychosomatic some of these things can be. I mean, I can be feeling perfectly healthy and start to read about medical condition. And by the end of the article, I start to think, well, that's odd. Perhaps I do have a tingling in my fingers sometimes.
Exactly.
It's like the new medical students who think they've got every disease under the sun.
I mean, that's the commonest story. Yeah, medical students are constantly focusing too much on their bodies when they learn new things. But precisely as you say, I always use the beginning of the COVID pandemic as an example. It was a very frightening time for everybody. But as a doctor working in a big hospital, you know, with an acute medical intake, we were all very terrified at the beginning. I always remember how frightening it was. And we were learning that doctors in Italy, which had been hit harder than us, earlier than us, were dying, or suddenly doctors were caring for other doctors in the intensive care. It was a very, very frightening time. I recall turning on the news every day and being told, you know, X number of people have died. And then immediately following that, I was ordered essentially to examine my body and test myself if I thought I was potentially the next victim. My body was awash with COVID symptoms during that time, and I'm sure I wasn't alone. Noticed every time I walked upstairs and I got a little bit more breathless than I thought I should be, or feelings of potentially having a sore throat. And I was testing and testing and testing myself. It was never positive. As far as I know, I never got COVID, despite multiple times at the start thinking that I felt the impending symptoms. It's the most ordinary thing in the world to notice bodily changes if you are primed to look for them. Fortunately, I relaxed into the pandemic after a while and accepted that my anxiety was getting the better of me at times. I think sometimes people think about psychosomatic symptoms as something that only happen to people who are a bit mad or a bit vulnerable. Hey, they happen to us all, and they are incredibly real when they're happening. And for some people, they're really disabling. And that is a worry about a medical diagnosis is a medical diagnosis turns a healthy person into a patient. And when you turn into a patient, you can subconsciously begin acting like a patient.
Now, one of the medical conditions you talk about in your book is autism, which clearly for some people has a huge impact on their day-to-day lives and what they're able to do. But the diagnosis has now been expanded to the point where far more people are believed to have the condition. So do you think we are diagnosing that too easily today?
The first thing I want to make super clear, I do believe autism is subject to overdiagnosis, but I don't want people to understand that to mean that I'm saying that those overdiagnosed people are not suffering or do not need support or do not have a problem that needs to be addressed. When I talk about overdiagnosis, what I mean is there is a point at which medicalizing suffering is not exactly the right thing to do. It shouldn't be seen to negate the suffering, but rather ask the question, is referring to the suffering in a medical term the right way of going about things? I do think that it would be very, very hard to say that autism isn't overdiagnosed. As a diagnostic concept has expanded unbelievably enormously in the last kind of 70 years or so. It began as a disorder that affected people mostly with learning problems, and it was a very severe, what was referred to as autistic aloneness. So a person with autism in the 1940s would be someone who had zero interest in people, didn't interact with people, was more interested in furniture than people. And that was the literal description that was given by Leo Cano, who first described a cohort of cases. And then over time, particularly in the 1960s, people realized that this kind of aloneness and these traits that fit with autism could be present in milder forms. I think that was a really important realization, because there are people who don't really fulfill this description of aloneness. You know, they are interested in people, but perhaps their communication is different than would be typical, and they need extra support with communication, or they have obsessive interests but are not learning disabled. So the concept of autism expanded in the 1960s. I think that was important. I think it's important that we worked harder to recognize autism. I was in school in the 70s and 80s, and nobody in my class of 120 that I know of was recognized as having any special learning needs. Well, that can't be right. There must have been people who would have flourished had someone realized they just needed to learn a bit differently or they needed support. However, I would say that since then, things have continued to expand and expand to the point that we are now diagnosing autism in people whose impairment or difficulties are very minimum. In order to have a diagnosis of autism, one must have certain traits, and they must be present in every environment. They're not supposed to be just at school or just in one environment, and they should cause impairment. And I think that autism is now being diagnosed in the absence of very significant impairment. And that means that people with quite mild difficulties are potentially being medicalized. I think that autism has become a label that one has to get in order to get one's support for one's child in school. I think that for teachers to justify funding, a label is needed, and that encourages the diagnosis of difficulties as neurodivergence or autism. I think for a variety of reasons, diagnoses like autism have become, I was hesitating over the word attractive. They've become attractive. I don't mean that to sort of say that people are taking them on in a trivial way, but they've become useful ways of accessing help. So for lots and lots of reasons, autism is being diagnosed. And what I think is very interesting, it's not being diagnosed more and more in its severe form. What we're seeing is this huge growth in autism in the very mild end of the spectrum. The reason I say it is overdiagnosed, so my definition of overdiagnosis is that the diagnosis or the suffering may or may not be correct, but it's not beneficial. And the purpose of diagnosing more and more autism in children in schools was to protect their long-term well-being, to improve their long-term mental health. We're not seeing that. The increase in autism began in the 1990s. We're now in 2025. We've had well over 25 years of increased autism diagnosis. I appreciate that people will say, hey, we're not good enough yet at helping people. But, you know, we've had 25 years to look at the impact of increased autism diagnosis in school. And what are we seeing? Well, we're seeing worse mental health in young adults than we've ever seen.
The problem is it might actually make me start to limit what I do and what I think I can do because of the diagnosis.
Well, that is my very specific concern, is that, you know, if you take somebody with mild difficulties in school and refer to that as a neurodevelopmental brain problem, what you're essentially saying to a teenager is your brain has not developed normally. You have abnormal wiring in your brain. Now, some kids will shrug that off, but not every kid will be able to do that. For some children, that will sort of make concrete the difficulties that they have. It will make it seem that those difficulties cannot be overcome. Other people will expect less of that child because of the diagnosis. They may expect less of themselves. It focuses a person on what they cannot do, and that can become a self-fulfilling prophecy. I think we should be supporting children without these labels and encouraging children to look at their strengths. I should say I'm always talking here about the very mild end of the spectrum. Rather than diagnosing more and more people with very mild neurodivergence, we should be recognizing struggling children, supporting them without labels, and encouraging them to focus on what they can do, not on what they cannot do.
It also begs the question, what's the upper limit for this? Because if the cases of mild autism are growing every year,
yeah,
what is the upper limit? Is it half the population? Is it a third? Is it a tenth?
Well, it is concerning, isn't it? Because even though I feel that there's an obvious overdiagnosis crisis, not everyone agrees with me. And many of the people who actually work in this field are still fighting for more diagnosis. And it's really interesting to observe how that happens, because it has the look of science about it, but it's not a terribly scientific process. At some point in the last 15 or so years, somebody said, hey, we're diagnosing loads of boys with autism, but we're not diagnosing that many women. So we must be underdiagnosing women. And then they apply the diagnostic criteria to women or young girls and find they don't have autism. So then they say, well, autism must look different in young women and girls. So then the next step in that thought process is that they look at the girls, describe behavior of the girls that could potentially be called abnormal or troubling or troubled, and then they call that autism. They've created the criteria specifically to fit with the group that they want to diagnose. It's quite a bizarre how this can happen and that people don't notice, because what will happen then is that mainstream media or social media will say, hey, this problem has been underdiagnosed in girls for ages, we know that. And then they will say, girls present with autism differently. Well, how do we know that? Well, we don't know that. There's no biological markers for any of these things. Someone, an academic, has literally decided this is what autism looks like in girls based on their observation of girls. And then they apply the criteria to girls, and of course they find them. So, people are still making that argument, despite the fact in Northern Ireland, 1 in 20 children is said to have autism. I mean, that's an astonishing number. In the US, it's 1 in 36. Worldwide, it's about 1 in 100. And despite those huge numbers, people are still trying to make the criteria more inclusive, particularly for girls and women. But that is in no way based on science. That is entirely based on trying to create equality of diagnosis. But, perhaps equality of diagnosis doesn't exist in this.
Women don't get prostate cancer. It doesn't mean the tests are wrong.
No, and that is the thought process that's happening. I often find this happens in mental health diagnoses. This isn't a specific example. It's more of a general idea, because I can't remember what the paper actually said. Reading a paper, for example, that said Hispanic men in America don't have as many mental health diagnoses as other populations. And therefore, the assumption is that Hispanic men must be underdiagnosed. And therefore, you go into those populations and you actually foist diagnosis upon them. This is a recurring theme in mental health diagnosis, is if one group appears to have less diagnosis than another group, then we actively seek to spread our diagnosis into those communities. Whereas it could be, for example, in the case of Hispanic men, it could be that they have better ways of dealing with life's various struggles than other populations. It could be that they conceptualize these difficulties as part of their social functioning and as part of their environment and as part of their background, and that they deal with it that way.
And there might be genetic variability as well.
Exactly. But, we foist diagnosis on new populations. We regard them as deprived
and underdiagnosed.
Exactly. And that's what I feel has happened. I should say again, not everyone agrees with me on this, but the process one cannot deny, which is that someone literally just decided not enough girls were getting this diagnosis and changed the criteria to make it possible to diagnose in women. And that's a very unusual process.
But isn't the root of this, because we don't have any biological tests, it remains a hugely subjective process. And the difference between a variety of personal traits and when a disease starts is not an objective decision.
Precisely. I mean, there is no beginning or end to these. And, what is autism? I don't believe that anyone thinks that autism is a single thing, but rather it's a set of behaviors that can arise for a variety of reasons. But because we're diagnosing them entirely on behavior, there will never be a discrete beginning or end to it. The point that we should be recognizing is the point at which that diagnosis has ceased to be useful. No scientist can say you do not have autism and you do have autism. By the way, this entire conversation applies equally to prediabetes, hypertension, loads of physical things as well. We keep changing the criteria to make them more inclusive on the assumption that the more inclusive a diagnosis is, you'll pick up more people, you'll treat more people, and you'll get better long-term health. And when we change a criteria, the success of that changed criteria is very often measured on how many extra people with the thing we can find. So if I change a criteria for autism and I find that, hey, loads of girls have it, well, then I'm a successful person who's found loads of extra people with a diagnosis. Or if I change the hypertension limit, it's the cutoff between normal blood pressure and high blood pressure, and I find millions of new people with high blood pressure, the success of what I have done is measured by all these new people I've found.
Or I suppose for a GP with cholesterol levels, those levels have dropped and dropped the level at which they think is appropriate to prescribe statins. And of course, GPs get a financial incentive for every patient they put on statins.
Yeah, although I would always say that GPs are not the root of this problem at all.
They're following NICE's guidelines.
Yeah, and this all comes from specialists, to my mind. GPs are a good protection against overdiagnosis. Yes, they are paid at the moment and incentivized to find people with high blood pressure and high cholesterol, etc. They're following the guidelines of specialist committees. I think what needs to change is that, every time a committee says, right, I'm going to adjust the criteria for diagnosing high blood pressure or autism or anything, what they need to do is, first of all, establish how many extra people they're going to turn into patients. And then much more importantly, they need to establish what is the benefit to that group. It can't just be enough to say, I've found this many extra people, and if I treat 100 extra people with borderline high blood pressure, I can prevent one stroke. And they'll say, great, I've prevented a stroke. What happened to the other 99 people who didn't need the treatment? And I think we need these committees to pay more attention to that group.
And perhaps a little bit more scrutiny also on conflicts of interest in terms of links to pharmaceutical manufacturers. Many pharmaceuticals do a very valuable job, but clearly there's a conflict if one is being paid by, say, a blood pressure manufacturer and also sits on a committee like that.
Yeah, I think there certainly are conflicts. I mean, the ADHD criteria have relaxed a great deal also, and members of the DSM committee that expanded the concept of what it is to have ADHD.
Is it worth us just taking a step back, looking at the DSM, which for anyone that doesn't know is the US Diagnostic and Statistical Manual of Mental Disorders, first published in 1952. But what is interesting, Suzanne, we've been talking about increasing criteria, but also this manual has substantially increased the number of listed mental health conditions every year. So now, for example, in addition to autism and Asperger's, we've the social pragmatic communication disorder, and there are many, many others that I could point to. Surely that's a problem too.
I mean, it's a huge problem. First of all, I think some doctors who think as I do also think that they would disband with the DSM, the Diagnostic and Statistical Manual, altogether. I don't feel that way about it. I think it has its use because in order to study something scientifically, in order to create treatment pathways, in order to sort of identify what treatment might help a person best, we do need to gather people into categories to a certain degree. I think the difficulty is that people take it too literally. Once a disorder enters the DSM, it becomes like something super concrete, as if it was scientifically proven by some biological fact. But actually, taking ADHD as an example, there's no biological markers for that at all. It is merely a collection of symptoms that has been gathered under the banner ADHD in the DSM. But that doesn't necessarily always communicate itself to the general public that, we've just decided to refer to these difficulties as ADHD. It doesn't mean it's definitely a biological problem or a discrete disorder. I think once something is in the DSM, it becomes the focus of research. And once you have lots of researchers working on a problem, and then you have a clinic set up to treat that problem, then that's kind of promising longevity to that problem. And that's a bit of a problem in itself, so it's hard to dial back on issues like ADHD that seem to be growing exponentially now.
I mean, the Americans are diagnosing this in 1 in 10 children?
Yeah, I mean, it's a state-to-state variability. Some states it's 1 in 14, in some states it's 1 in 7. I've forgotten the specific numbers now, but yeah, the numbers are astonishingly high. It's said to be about 4% in the UK, but growing. I think that the DSM, part of that is pharmaceutical industry, but I think we let ourselves off the hook completely when we blame everything on the pharmaceutical industry and on conflict of interest to do with pharmaceuticals.
Presumably, knowing how difficult children now find it to concentrate, I would imagine factors like mobile phones and other screen use would also be important.
I'm less convinced by that.
Interesting.
So I'll come to that in 1 second, but I will just finish what I was going to say there. We love to blame pharmaceutical companies, but we have a thirst for explanations ourselves. There's no drug treatment for autism, but people are still queuing up to be diagnosed with it. We go to our doctors asking for explanations, and our doctors, increasingly, if they have an explanation, they will give it. It's a kind of a collusion of the two groups of people. But there's this incredibly strong narrative running through society at the moment that, all of these difficulties and the deteriorating mental health in young people and increasing ADHD diagnosis are all related to social media or telephone use. Actually, ADHD was growing long before we had telephones. I'm not saying they don't have some contributory factors, or I'm not saying that they have not harmed children. They certainly have. And I'm not saying there's not harmful content there. But the evidence that the root of our mental health crisis is social media or phone use is actually very weak. The explosion of diagnosis began long before social media, and it began long before phones were in use. But also, if you do longitudinal studies looking at mental health and social media use, you find that there's very little relationship between the two. That's not to say, of course, that nobody has ever been harmed by the harmful content, but it may be that vulnerable people are drawn to harmful content. It may be that people who have mental health problems use phones more because they're more socially isolated, but that social media and phones are actually causing all of this difficulty. It's just spoken of so kind of blithely in society now that we all just kind of think that is the case. But when you look at the science of it, it's remarkably lacking in evidence, that view.
What's your position on this? You've got the hard line that says ADHD doesn't exist at all. And then you've got, again, a bit like autism, people saying it's still underdiagnosed.
Yeah, so I don't think ADHD is a discrete thing. So I don't think there is a thing called ADHD and everyone who has this particular set of features must have this genetic tendency or this biological abnormality in their brain. I think that there are children who have severe attentional difficulties, and haven't met many of them in my life, but I've met 1 or 2 children who are so hyperactive that you really would say, well, that is a problem. They could not sit still in school. So I believe that there's a cohort of children whose attentional difficulties and hyperactivity is so severe it affects their functioning, and it's reasonable to give the label of ADHD to those people because they are impaired by the attentional difficulties that they have, that they would not be able to progress easily through school. Such an important part of life. You need to support kids to be able to stay in school. So I don't think those children all have the same thing wrong with them. I'm sure that there are many difficulties in their lives, that kind of things that can make one vulnerable to ADHD in childhood, often begin in early life and are related to fetal alcohol syndrome or very difficult social early lives, etc. I don't think they all have the same thing, but they have the same set of difficulties. It's reasonable to label them as ADHD so they can get the right support. I think going forward into adulthood, I think that ADHD has become a label that is a useful way of communicating distress. It lets people know that you're in difficulties and that you need a particular kind of support. And it is a label that's used to describe such a range of difficulties now. When you hear people talk about ADHD, one person will say, well, I'm hyper-focused, and the next person will say, well, I've got no focus at all. Or one person will say, well, I can't sleep, and the next person will say, well, all I do is sleep. It's now become such a kind of heterogeneous kind of set of symptoms that almost anyone can qualify for this diagnosis. I'm not for a moment saying that these people are not suffering and don't need support, but it's become an intelligible way for people to ask for support. And that's one of the reasons it's become a growing diagnosis. But I don't think it's a discrete thing. And I'm far from convinced that taking this medical term from people who really need it in early childhood and giving it to a whole new set of people is a good thing. It's harmful both to the original ADHD children who do need support because it takes resources away from them, trivializes their suffering, and it changes the concept of what's going on with them. And it's harmful to this new set of people also because of the labeling effect of focusing them on their difficulties, and it gets in the way of social and environmental change that might actually be more useful to them.
And I suppose the other risk factor is if they end up on the common medication Ritalin, we don't really know what the long-term impact of that is on a child's developing brain.
Obviously there's been loads and loads of studies on Ritalin, but they're not generally long-term studies. They're very often sort of 12 weeks long. They're quite short studies. So we don't have a really great idea of how that will affect children in the long term. And we know even less about the impact in adulthood. I think that it's very worrying how absolutely terrible we are at learning from history. I mean, when drugs like benzodiazepines were being used very freely in the 1980s, people didn't understand how addictive they were or how harmful that could be in the long term for people. We have the opioid crisis. When you take drugs that are stimulants and you give them to big groups of people, you don't always know where that's going to lead. I'm not suggesting that I know that Ritalin use or stimulant use will lead somewhere awful, but I know that I would be very loath to take a medication that hadn't been studied over the long term, and we need to be more cautious with that. Also, people do need to understand that stimulant drugs, they're not treating anything really. They're merely medicating your behavior on the day that you're taking that drug. That is not going to have a lasting effect. If you really want to feel better and deal better with the world, then you need behavioral modifications or environmental modifications or social modifications. That's how you get long-term improvement. But taking a stimulant drug just helps you on the day that you take it to concentrate better on mundane things. It's not really having a positive effect on your brain in the long term.
More broadly, if one looks at other parts of the human condition, such as sadness and depression, do you think we're at risk of pathologizing normal human emotions? I mean, just looking at the DSM manual again, they talk about a possible diagnosis of depression if you feel sad after a death 2 weeks before. I mean, I'd argue there's something wrong with you if you didn't still feel sad.
Yeah. So grief has been included in the DSM for the first time, and obviously that's been subject to a lot of criticism. I do understand that people make these decisions to put things like grief in the DSM. It's because there are practical considerations. I think more in the States than in the UK. In the UK, we don't need to sort of have a medical label in order to go to the doctor or to justify payment by insurance companies. But putting something in the DSM means that someone can potentially get on a treatment pathway, which they couldn't get on if it wasn't in the DSM. I think there are practical reasons that these sort of things are done. But I kind of want to remind people that we are all responsible for this. We can kind of look at pharmaceutical companies or the DSM or psychiatrists and say, hey, they're diagnosing too much stuff, or the DSM has become too inclusive. But DSM is responding to society and is created by people, specialists, scientists, doctors who live in society. I believe this is a societal problem. We have come to expect perfection of ourselves, and we have created these awareness campaigns around mental health, which are designed to make people feel brave enough to come forward. But in doing so, we are also instructing people to worry about things that they didn't worry about before. So I think the solution is not just in medical and scientific corner, it's societal issue that we have.
I mean, there's certainly much more talked about mental health today, which is always seen as something positive.
Yeah.
But I wonder if that is always the case, or if it leads to more self-diagnosis, or people thinking perhaps they're depressed when actually, for very good reasons, they feel sad, as we all do at points.
Obviously, mental health awareness campaigns were created for good reason. Again, if I go back to sort of my teen years or 20s, don't think people were terribly keen on admitting to suffering or admitting to have a mental health problem back then. I'm sure that underdiagnosis occurred. So destigmatization was necessary to a certain degree, and awareness campaigns would help with that. So it's all very well-meaning, but I do absolutely think that the awareness campaigns perhaps have gone too far now. There was a very interesting study in the Department of Education published in February that compared two cohorts of school children. And one group of school children in their teens was given mental health awareness training, and the other group at a different school, I think, were not given mental health awareness training. And when they looked at the emotional well-being of these two groups of teenagers 12 months later, they found that the group who had the mental health awareness training were much more symptomatic, had much more negative symptoms than the group who didn't. And that's just a perfect illustration of, if you tell a bunch of people to worry about low mood and to worry about anxiety and to worry about the night they couldn't sleep, that those things risk being pathologized, and they'll notice things they wouldn't have noticed without the awareness training.
Isn't that interesting? I noticed a friend of Facebook, actually, she marked the other day that she told her mother when she was about 8, she thought she was depressed. And her mother said, don't be silly. Children don't get depressed. Go out and play in the garden. Obviously, it can't have been anything very serious.
Yeah.
But there is an element of it. I mean, I can remember as a kid, one of the things which I'm sure all kids go through, we say, oh, Mum, I'm bored. We'd always be expected to go out and do something rather than her worrying that there was something sort of underlying.
The conversation is very difficult because one doesn't want to sort of say, let's go back to the 1950s where you just snap out of it.
Yeah.
Even 70s or 80s, where the attitude was just get on with it and snap out of it. You know, I don't want to go back to a period of not recognizing that some children have more needs than others and not recognizing that the world isn't an equal place for everybody. But there is an element of a need to return to a bit more balance of accepting that low moods happen and accepting that when you have a low mood in the more mild end of the spectrum, sometimes getting on with it is the best thing to do. I know this for myself. If my kind of mood goes down and my absolute inclination is to cancel all social occasions and meet people as little as possible, I know for a fact it's the worst possible thing for me. I'm snapped out of it by going out into the world and having my attention drawn away from my own inner world and into the outer world. So I do think we need to work harder on helping people to know how to overcome those low times, and pathologizing them with medical labels and wrapping ourselves in cotton wool isn't always the right thing.
Now, you also talk in your book about tests, particularly those which may predict our chances of getting a disease. And it's not an easy decision for a patient to decide sometimes whether to have one of these tests. And a particularly grim disease you mention in the book is a degenerative illness called Huntington's disease. And if you have a parent with the condition, you have a 50% chance of developing it. And there is a test available, but actually many people decide not to have it. Why is that?
Yeah, I opened The Age of Diagnosis writing the story of this lady called Valentina, not her real name. When she was 28 years old and pregnant with her first child, she discovered completely unexpectedly that her mother had Huntington's disease. Now, for people who don't know, Huntington's disease causes severe neurodegeneration that ultimately shortens your life. It presents with psychiatric symptoms and motor symptoms. At its worst, you can't walk, you can't swallow, you can't speak. It's a very unpleasant disease that is at the moment untreatable. Hopefully that will change. It's a genetic condition. If your parent has it, you have a 50-50 chance of inheriting it. So when Valentina discovered that she was at risk of this, her mother's diagnosis instantly meant that she went from being a perfectly healthy first-time mother to being a person with 50-50 chance of getting Huntington's, and her child immediately had a 25% chance. Now, she could have had the test then and there that would have told her one way or the other. She would have gone from 50-50 to either 0 or 100. She didn't do that. And this is the story of most people in her position. 80 to 90% of people who can be tested for this untreatable condition do not take the test. And that's because they're a community that understands the impact of getting that positive test. So let's say you have a genetic test and you learn you're going to have Huntington's disease, but you're only 28. So if you're going to get it, you probably won't get it till you're 50. So you've now got 20 odd years to live with this thing bearing down on you. What potentially happens then is suddenly you notice everything about your body that isn't normal becomes heightened in your awareness. And diseases like Huntington's or Alzheimer's, for example, is another example of this. They begin with things that happen to all of us. You lost your keys. You got angry at your husband. You tripped over a paving stone. The minute you find out you have the gene and you're going to get the disease eventually, you will notice every one of these things, and that can potentially disable a person 20 years before the disease even starts. And the Huntington's disease community understand that once you know you have an impending disease, you cannot unknow it, and it will take over your life. What happened to Valentina was she decided not to test because she talked to a genetic counselor. Genetic counselor helped her to understand that, she should be focusing on the happiness in her life now and not on worrying less about what might happen in 20, 30 years' time. And she was a first-time mother. She wanted to enjoy that. She had a baby without testing. She had another baby without testing. And she did enjoy her life. However, the risk of Huntington's disease was very burdensome for her. She started noticing that she was getting it, essentially. She started noticing she was tripping over things. She had to go to an airport. She couldn't organize things. Her organizational skills were terrible. She'd walk into an airport having to have a boarding pass, a passport, know where you had to be at a specific time was too much. She just couldn't organize things. She was snapping at her husband. She was tripping over things. She was bumping into things. And she just kept putting off testing. And as she said to me, the minute she tested positive, she would have to look at her beautiful, healthy, happy, growing children. And she would know that they were now going to go potentially through what she was going through. She waited about 20 years to finally take the Huntington's disease test. And it was negative. She actually didn't have the Huntington's disease gene. Now, when I tell people this story, they often kind of say, well, my God, she should have just tested when she was 28 and then she would have known. But look at what she was risking. If she had tested when she was 28 and it had been positive, all of these things she was noticing about her body that were nothing to do with Huntington's would have been reinforced and reinforced. The Huntington's might not have started till she was 50, but from 28 until 50, she would have been weighted down by all of these symptoms that had absolutely nothing to do with the disease. I started the book with that story, even though I know almost nobody will have her experience. But I want people to understand that if you tell someone that they have an impending disease, it can take over their entire well-being. It can destroy their health just knowing that, even if they were never destined to get the disease in the first place.
I suppose it's different for everyone, but I remember meeting a man in his 70s who had a family history of Huntington's, and he'd never been tested. But due to his family history, he and his wife had decided not to have children. And obviously by then in his 70s, he didn't have Huntington's because he would have developed it by that age. But it seemed to me in that particular case, he might as well have had the test because he'd made key decisions in his life, assuming sort of that he did have Huntington's.
I should say there's really important practical reasons to test, and having children is one of those. Interesting, Valentina decided not to test before she had her second child, and she said something kind of very moving to me. She was pregnant with her first child when she learned she was at risk of having the gene, so that child was instantly sort of at risk. She couldn't turn back time on that. When she went to have a second child, she knew that this disease gene was in the family, and she could have had a test to find out if she was positive, and that would help inform her on the pregnancy going forward. There also are techniques now that you can have IVF pregnancy where they pick out the healthy chromosome so that your child has the lowest possible chance of inheriting the gene. She didn't do that either. And when I asked her about it, she said that she just could not do that to her children. She could not imagine a conversation in the future where she had to sit down her two children, and the oldest child who she'd had before she knew about the HD gene, she'd have to say to that child, well, you might have it. And then she'd turn around to the other child and say, but you've been specially chosen and therefore you don't have it. She couldn't face having that conversation. I totally understand that. So I think it's one of those super individual situations. Some people know they can't live without knowing, or people have families that they want to protect going forward. So it's perfectly valid to test. But I think it's interesting to note how few people do actually test. And I think we need to listen to that lesson. These are people who know something very important, and we should be listening to them.
And what about when it comes to predictive tests for cancer? I mean, you talk about the BRCA gene, which for women most prominently means an increased risk of ovarian and breast cancer. How does somebody weigh up the balance there?
So I think it's super useful to have these predictive tests. So the gene for breast cancer, it's not just breast cancer, but ovarian, fallopian tube, and other cancers are associated with BRCA. Prior to the 1990s, before these genes were discovered, there were people who knew they had cancer in the family, but were powerless to do anything about it. And then we discovered that the BRCA genes increased everybody's risk of breast cancer, but obviously women are most affected. And that immediately put us in a situation of being able to tell people what their risk is. And that's so well developed now. The gene was discovered in the early 1990s. So we've now had a lot of years in order to follow the statistics of people with the BRCA gene over time, so that geneticists can do very sophisticated statistical analysis that will inform a woman of their specific risk. So I wrote a story of a lady in the book whose mother and grandmother both had cancer at the same time when they were very young. And it turned out to be a genetic cancer. They had a BRCA gene. She was found to have the BRCA gene in her 20s and was advised that she had 80% risk of having breast cancer and a very high risk of developing ovarian cancer. And being in that position, it empowered her to make a decision for herself. And the decision she made for herself was phenomenally difficult. She had her healthy breasts removed. She had her ovaries and fallopian tubes removed when she was extremely young, only in her 30s. She found the whole experience hideously traumatic, just very psychologically difficult. But she had seen her mum fight cancer twice and she'd seen her grandmother die. So as awful as the surgery was, she felt like it was worth it. So up to this point in the story of the BRCA gene, I'd say, hey, this is amazing that people are able to assess their risk and have a choice. But it's after this point that I have difficulty with the BRCA gene story. Science does this thing. It finds something that is game-changing. You know, it's fabulous for families with cancer to be able to have this test and potentially take evasive action that will prevent them from getting cancer. And even if they don't have surgery, they can have screening. So this is a fabulous innovation. What medicine does when it has a fabulous innovation is it then says, hey, you know, I've saved all these lives. What else can this test do is the next thought that medicine has. So now BRCA testing is not just being used in a focused way. We are now extending that testing to people who have no family history of cancer. So we're saying to the Jewish population have a much higher risk of having the BRCA gene than other populations and a higher risk of developing genetic breast cancer. So now this type of testing is being extended on a research basis to Jewish people or people with one Jewish relative who have no cancer in their family. And this is where overdiagnosis in medicine becomes a problem. We think that if something is useful to one group of people, it will be equally useful to another group of people. And we don't consider the downsides. It's the same as with autism. It's clearly advantageous to a person with severe autism to have a diagnosis and get help. It's substantially less clear if that still applies in the mild group. Now we're doing that with something as sophisticated as genetic testing. We think if we can save lives of people with family history of cancer because we genetically test them, that we'll save just as many lives in the non-family history group. What we are failing to admit to the public is how little we actually understand the risks that come with these cancer genes. We've only ever studied them in people with a family history of cancer. They have not been studied at a large population level in the whole population in people who don't have a family history of cancer. We've no idea.
Which might mean, for example, they're less likely to turn on, possibly.
Well, there could be loads and loads and loads of us who are walking around with disease genes and we don't know it because we have never had a reason to be tested. If you don't have a family history of Huntington's disease and you don't have a family history of cancer, you will never have had a genetic test for Huntington's disease or cancer because we never did that before because we couldn't do it. Now we can do it, so we do it. There's an interesting example is a gene for diabetes. If you have a particular gene that puts you at high risk of developing diabetes and your family has diabetes and you test positive for this gene, then you have a very high risk of developing diabetes too. But if you have this gene and you don't have a family history of diabetes, there's no increased risk of developing diabetes. And there could be lots of reasons why this gene confers a risk of diabetes to one group, but not to another. It could be that these people who get the diabetes are missing a protective gene that the rest of us have that we haven't discovered yet. Or it could be that these people who get the disease, they don't just share genes, they also share an environment and a lifestyle. It could be that there's multiple other factors that these people share that could be genetic and non-genetic factors that produce the disease. It could be the same for the cancer gene. It could be that the families who get the cancer also have some other gene or are missing some other gene that put them at risk, that the rest of the population doesn't have the same risk because they don't have those same genetic factors. And it sounds so logical to say if you have this gene, you might need this treatment. But we're not being entirely honest that there's so much of this we don't understand. And we're not being honest that every time we extend a test to a new population of people, we're essentially experimenting on that new population of people. I think we need to be more honest with people about that. We need to be a little bit more honest about all the unknowns.
And the other thing is, I can understand having prophylactic surgery for women who are very high familial risk, but having an early hysterectomy puts you into early menopause, which also carries a number of other increased health risks, including an increased risk for some cancers.
The problem with cancer screening in general, so I don't want to put off anyone from cancer screening. I just want people to enter into the mandatory screening with the full knowledge. If you screen loads of people for the BRCA gene, or you screen loads of people for breast cancer through mammography, and you find loads of people either with early cancers or with a high-risk gene, and then you treat them, the consequence of that is if you look at cancer survivals, you'll see much more people are surviving because you are potentially over-treating lots of people who would have been fine anyway. There's two ways of looking at the success of early cancer or cancer screening treatment. You can look at it as cancer survival statistics or as all-cause mortality. Just looking at cancer deaths means you're only looking at people who died from the cancer that was treated. Looking at all-cause mortality means that you're looking at deaths for any reason. When you look at all-cause mortality of cancer screening programs, you find that all-cause mortality is not impacted in the vast majority of screening programs. I think there was an improvement of about 12 weeks in lifespan in the colon cancer screening group. But for most cancer screening programs, you do not improve all-cause mortality with cancer screening. You will definitely be saving some lives from cancer, but you will also be over-treating other people. So you're helping some people and saving their lives, and you're subjecting another group of people to drugs or surgery that they didn't really need. And those drugs or surgery will have a negative effect on some of those people. So you are foreshortening the lives of some people with unnecessary treatment and saving the lives of other people by giving them treatment that was undoubtedly necessary. It's very difficult. If I were to have, and I do have regular breast cancer screening, but I go into it with the knowledge that if something is found, it isn't necessarily necessary to treat that. That a lot of very early cells do not grow. That's why cancer overdiagnosis occurs. A lot of cells that look cancerous will never change. If you look at older people who've died for other reasons, you'll find small cancer cells in lots of them. So if you find something on screening, it might turn into a malignant cancer, but there's a way, way bigger chance it won't. And the kind of numbers we're looking at is one Cochrane review. So a Cochrane review is a review of all available evidence. Said that if you screen 2,000 women for breast cancer, you will save one life, and you will treat 100 women for cancer who didn't need to be treated. For every life saved, you're giving a great many more people treatment that they didn't need. So my personal strategy will be, if I go to breast cancer screening and they find an abnormal cluster of cells, assuming it's very localized and very small, I will ask for watchful waiting, which means that I will have a series of scans that will allow me to see if there's any evidence of growth in these abnormal cells. If there's no evidence of growth, I won't necessarily ask to be treated. But if they change in size or appearance at all, then I will ask for all the bells and whistles.
But most patients obviously would be terrified by that approach.
Well, that's the problem, isn't it? There's no standard prostate cancer screening in the UK or in most countries, and that's because there's a massive problem with overdiagnosis. If you screen for prostate cancer using PSA or prostate-specific antigen, there's a huge, huge overdiagnosis problem. So lots of men will have treatment that they didn't need. But if a man goes to his doctor and discovers that he has a high PSA and potentially has prostate cancer, most will ask for the treatment, not all, but great many will ask for the treatment because it's so frightening. And one argument for this is that we need to give these things different names. Cancer found because you're symptomatic. So let's say you're in the shower and you find a lump in your breast, or you've got an actual symptom that you found. It's not been found through screening. That type of cancer needs immediate and urgent treatment, and that is what everyone expects they have if they have these early cells. Not every one of these early cells will progress in that way. So the argument would be we should be giving them a different name, because the minute you call them cancer, everyone just immediately, the mind will quite naturally go to that life-threatening cancer situation. But some specialists would argue that if we gave these early cells found on screening a slightly different name that didn't imply that they are all exactly the same thing as malignant cancer, that it would be easier for people to feel that they can sit back and think for a while, because most of these things can be sort of thought about for a little while. You don't need to panic into action.
So would this be largely stage 1 cancer, where you personally might choose to take a delaying approach?
Yeah, so I'm not an expert in cancer staging, so I'm not going to say about stages, but this is when you screen for cancer, someone is completely healthy, 100% asymptomatic, and you screen them for cancer and you find just a very small localized abnormal cell. Not every one of those cells will grow into a symptomatic cancer. If you have symptoms, you always need to be treated. If it's been found in some way other than screening, you need to be treated. But if you are just found to have a very small cluster of abnormal cells on screening and you are 100% well, it is perfectly reasonable to have a discussion with your doctor about watchful waiting, and there are some watchful waiting programs. And what that means is that rather than immediately jumping in with the aggressive treatment, that you maybe wait a couple of months and have another scan and see, has anything changed? If it's changed, you need the treatment. If it hasn't changed, you can continue having serial scans over time to make sure that you remain well.
But interestingly, there was a paper this year which suggested that some scans may even be causing cancer. This is related to CT scans. And it reported that CT scans may account for 5% of all cancers annually. And the paper said that they predicted 103,000 cancers will result from the 93 million CT scans that were performed in 2023 in the US. If that is anywhere close, that is really alarming, isn't it?
And that's one of the real big concerns about mammography, actually. If you do too many scans, a big concern of some groups is that serial mammography might be causing as many cancers as it catches. Of course, there's safer ways to have scans. If I were found to have abnormal cells, I would ask for serial MRI, which doesn't come with radiation. There are safer ways to do imaging. But yes, I think we have to be aware that every time we have a test, that's not inert either. It either turns up unexpected findings. I always have to remind people that MRI scan wasn't available clinically until the 1990s. And the type of MRI scans that we have now that are super sensitive and can see tiny abnormalities have only been around for a decade or two. So we didn't even know what the inside of a healthy body looked like until the last 20 years, because we never investigated healthy people. Therefore, we had no idea how many lumps and bumps and undocumented things were on the inside, because we didn't have the ability to look. CT scan has always been used a little conservatively because we were always aware that it had the potential to cause cancer through radiation. But MRI scan, sure, we can MRI anyone because it's understood to cause no harm. We're still figuring out how to distinguish the important things we find from the less important things. And there's a temptation to do a scan to reassure somebody. I wouldn't do that, because if you reassure someone with a scan, you are running a very high risk that you will find a cyst or some slight abnormality in a blood vessel that isn't important to their health. But if you've done the scan to reassure them, how reassuring is that exactly when you find some inconsequential finding on the scan? So I think we need to remember that tests come with their own set of problems, and a lot of doctors would not have a medical investigation like a blood test or a brain scan or any kind of scan unless they knew exactly what they wanted to get out of that scan. It's not so much a thing in the UK, but it's much more of a thing in the US. There are people who have whole body scans to look at their general health as part of a health screen. I mean, I think a lot of doctors, myself included, would find that quite foolhardy because you're really putting yourself at very high risk of something irrelevant being found. And once you find something as a doctor, you can't ignore it. It'll lead to another test and another scan and then monitoring, and then you'll have a treatment that you didn't really need. And that's a rocky downhill road to something very unpleasant potentially.
But I wonder if sometimes doctors underplay the risks of CT scans. I'm just thinking personally. I saw a doctor last year who suggested I should get a CT scan, and I didn't think my symptoms justified it. And I raised the risk of an unnecessary scan, and she was very dismissive, told me it was a negligible risk. When I looked at the stats, I didn't think it was. So I requested an ultrasound instead. Anyway, my symptoms went away. I saw another doctor. They were horrified that a scan had been suggested and said no radiographer would have approved that.
I'm just wondering, what was the age of the first and the second doctor? I've come from a generation, I qualified in 1991. I've been a doctor a long time. I'm horrified at unnecessary tests, not just because of the radiation in a scan, yes, because of that, but also because of all of the hard to interpret findings and where that will lead. I wonder, and again, this is super anecdotal, I wonder if some of the more junior doctors who grew up with these technologies are a little bit more gung-ho. Was the first doctor quite a young doctor?
She was very old school. She was probably, late 50s.
Oh, okay, right, so not.
And not terribly receptive to anything I said. And I finally sent her a couple of medical links with risks to CT scans.
Oh, God.
She kept saying the risk was close to zero, and I knew that wasn't the case.
Yeah.
And after doing this, she then referred me for the ultrasound.
It really helps if you have this knowledge and you can advocate for yourself. I would want to ask, what exactly are you looking for? What are the benefits? What are the risks? And also, yes, if they said CT scan, I'd say I'll have an MRI scan. Thanks very much, because they don't come with radiation. My sort of anecdotal, I believe that young doctors might order more tests than older doctors didn't prove to be correct on that subject sample of one. I think there's a few practical issues here. I mean, first of all, I cannot tell people how much easier it is to order the scan than not order it in multiple different ways. Let's say that someone comes to me and they think they have a brain tumor because they have a headache. And I feel fairly convinced they don't have a brain tumor and they don't need the scan. Now, very often people come to you because they want the scan because that's what they believe is the most trustworthy thing, and that will put their minds at ease. The consultation that is required for me to explain why a scan is not needed and how a scan can be dangerous, that's a lengthy and detailed consultation that has a lot of nuance that requires me to explain it well and for them to understand it. That's a difficult consultation. The consultation where I say, I don't think you have a brain tumor, but I'll just do this scan to prove it, that's an easy consultation. I sometimes think that people, if they go to the doctor and the doctor is willing to do the test very easily without much discussion, they think, oh, that's a good doctor. They're doing everything possible for me. Not necessarily. That's actually quite an easy way of practicing medicine. It's also easier on us as doctors psychologically to do the test. So let's again take this person with the headache who thinks they have a brain tumor. And I feel pretty confident they don't have a brain tumor, so I don't want to do a scan. But what if? No one's right all the time. What if I'm wrong and I don't do the scan? Well, that's a thing I'm going to get in trouble for. People often think this is all about being sued or protecting yourself medico-legally, but I'm protecting myself psychologically. It's very, very upsetting as a doctor to have someone come back to you 6 months later and you discover you missed a diagnosis. And that's a difficult thing. So we will, in order to protect ourselves both medico-legally, but also psychologically, it's easier to do the scan. There's so many ways that pushes us towards doing that test. Because if I do the scan and they're discovered to have a cyst or a abnormal blood vessel or something that I think is irrelevant but causes them immense anxiety, nobody can sue me for that. Nobody will come pounding on my door saying you did the scan and it found the irrelevant abnormality. I'm furious at you. that won't happen. There's very little comeback when you do an unnecessary scan. But if you don't do a scan and something is later found, it's very, very difficult for a doctor. So many, many things push us towards doing a scan. I think the important thing as a doctor is that you don't do a test out of fear, but you be prepared all the time to reevaluate the situation. I work with people with epilepsy, which is a diagnosis you have to make purely on a clinical history. So all you are going on is a perfectly healthy person is sitting in your clinic room and they're telling you about an experience that happened 3 months ago, and they're not going to remember it properly, and maybe there's a witness there who panicked and is going to give you a very panicked version of what happened, and you have to make a diagnosis on that and that alone, which means you're inevitably going to be wrong sometimes. But how I deal with that is by seeing that person again, by making a judgment call and explaining to them why I've made that judgment call, but then seeing them again, being prepared to change my mind and being prepared to do the test at a later date if I hear the story differently. I think good clinical medicine will make up for all of the issues we have with tests.
So for the future, just how do we get the balance right between sickness, health, diagnosis? What you're describing, it sounds an almost impossible ask.
Well, I think it's very difficult, but I think that there is something that we're not utilizing properly, and that's clinical time with doctors. The thing that makes a good diagnosis and the thing that makes people better is a good consultation. And I think that doctors don't have nearly enough time. There's nuance in diagnosis and there's nuance in medicine. It's not a case of you have this symptom, you do this scan and you get that diagnosis. There are so many caveats and there's so much more to it than that. And doctors are struggling to get there because they have 5 minutes or 20 minutes. And I think that we need to value the clinical side of medicine, because a good diagnosis is made slowly and with thought and with time spent with the patient. So rather than investing in sort of genetic screening programs that we don't really understand, or extending diagnosis to new groups of people when we haven't proven that they're beneficial to old groups of people, we should be taking all that money and we should be ploughing it into GP practices that mean I can go to my doctor and spend 15 minutes discussing my problem with them and not 5 minutes. I think we need to start valuing medical professionals. I keep saying doctors, but I also mean nurses. I also mean speech therapists. I also mean physiotherapists. Time spent with the medical professional is how you get a good diagnosis and good treatment going forward.
Well, Suzanne, thank you so much for speaking today. Absolutely fascinating. Thank you.
Lovely to talk to you. Thanks for having me. Bye now.
Goodbye. Hope you enjoyed the latest episode of the podcast. And if you've enjoyed the podcast, if you could share it and leave a review on Spotify and Apple, I'd much appreciate it. It really helps. Many thanks for listening. Bye for now.